Uh, Thank you, Dr. Lang, for that wonderful introduction. Let me share my screen here. And it's a real pleasure for me to be here. I had the opportunity to participate in the session on meningiomas several weeks ago, and it's a real privilege to be able to be here again talking to you about low-grade gliomas this time, and some of the changes that are taking place in the new 2021 classification system. So the classification of gliomas has been modified or refined to incorporate genetic alterations in the definition of disease entities, and also as part of the grading criteria. And that's one of the major changes in the new 2021 WHO classification system. Some of that started in 2016, but it was taken to a next level and further detail in the recent 2021 classification. As a result, some infiltrating gliomas can be high grade, even in the absence of high grade histologic features. And that's just a point that I want to make. The traditional histologic features in gliomas, increased mitotic activity, vascular proliferation, and necrosis, for many years have been used to distinguish high-grade tumors from low-grade tumors. Now, under the new classification system, there are low-grade tumors that do not have any of these alterations, but they're still high-grade. And it's just as important to recognize when you're dealing with a low-grade tumor, and it's also very important to recognize when you're dealing with a tumor that may appear to be low-grade on histology, but it's actually not. So molecular characterization is critical for the classification and grading of gliomas. And I will give you some examples of how this is currently applied. There are 4 broad categories of gliomas in the new WHO classification system. We have the circumscribed astrocytic gliomas, the pediatric type diffuse low-grade gliomas, the pediatric type diffuse high-grade gliomas, and I will not be talking much about these. And we have the adult type diffuse gliomas, which includes the oligodendrogliomas, glioblastomas. The IDH mutant tumors would be in this category. If we look at the circumscribed astrocytic gliomas, we have pilocytic astrocytomas, which are grade 1 tumors. There's not much change in pilocytic astrocytomas. They frequently have this fusion, KIA 1549 BRAF fusion. There's a new entity, high-grade astrocytic with piloid features, which may mimic pilocytic astrocytoma on histology. It can have Rosenthal fibers, eosinophilic granular bodies, similar histology, but it's actually a high-grade lesion. It's typically in the posterior fossa, and it has loss of ATRX expression. So whenever I see a tumor in the posterior fossa with loss of ATRX expression, suspect this entity. Now, one of the challenges of making this diagnosis is that the histologic features of the high-grade astrocytoma with piloid features vary considerably and are not sufficient to diagnose this entity without additional molecular testing. And this is a theme that we're seeing over and over in the classification and grading of gliomas, is that you need molecular testing for accurate classification and grading. We have PXAs, polymorphism astrocytomas, can be grade 2 or 3. The classic combination of alterations for PXAs is a BRAF V600E mutation and homozygous CDKN2AB deletion. So whenever I see a tumor with these molecular alterations, I strongly suspect PXA as the diagnosis. SEGAs, which are grade 1 tumors, there's not much change in the classification or grading of SEGAs. They're usually periventricular, large astrocytes associated with tuberous sclerosis, mutations in TSC1, TSC2. Chordoid gliomas, usually in the third ventricle, they're grade 2 tumors. And now we know that the great majority of chordoid gliomas have a mutation in PRKCA gene, specifically in amino acid 463. And we have astroblastomas, which are defined by not just the histology of the astroblastic rosettes, but also having the MN1 alteration. Now, the pediatric type diffuse low-grade gliomas, there are four tumors in this category. We have the diffuse astrocytomas MYB or MYBL1 altered, which are grade 1 tumors. We have the angiocentric gliomas, which are also grade 1 tumors and are characterized by the presence of this fusion, MYB QKI fusion in angiocentric gliomas. And we have tumors that we call plenties, so polymorphous low-grade neuroepithelial tumor of the young, which are grade 1 tumors, usually associated with seizures, oligodendroglioma-like cells, so it's important to distinguish these tumors from actual oligodendrogliomas. Frequently CD34 positive, which is an immunohistochemical stain, and they have MAP kinase pathway alterations. And we have the fourth category of diffuse low-grade glioma, MAP kinase pathways altered. And as you can see, MAP kinase pathways alterations are very common in different types of low-grade gliomas. Usually BRAF mutations or FGFR1 tyrosine kinase domain duplications. These tumors have to be IDH wild type and H3 wild type. So they cannot have mutations in IDH1 or IDH2. They cannot have mutations in the histone 3 gene, and they cannot have homozygous deletion of CDKN2A/V to be put into this category of diffuse low-grade glioma MAP kinase pathway altered. So one thing to take into consideration is the pediatric type diffuse low-grade gliomas are more common in pediatric patients, but they can occur in adults. And they were given the pediatric type because of that propensity to occur in pediatric patients, but they're not exclusive to the pediatric population. Here we have an example of an angiocentric glioma. We have elongated cells. We have this angiocentric growth pattern. So you can see a blood vessel in the center, and these tumor cells are ranging around the blood vessel, and they have the characteristic fusion of MYB and QKI. We have PXAs. Here we have an example of a PXA, pleomorphic tumors, frequently multinucleated cells, as you can see here. Here you have the BRAF V600E immunohistochemical stain showing that the tumor cells are positive for expression of the mutant protein, and we have reticulin deposition in PXAs. And the characteristic molecular alterations of this lesion are BRAF V600E in combination with CDKN2A/V deletion. Now, I'm going to briefly mention two entities of the pediatric type diffuse high-grade gliomas, even though that's not the main focus of this presentation. And the reason I'm going to talk about these two lesions, the diffuse midline glioma H3K27 altered and the diffuse hemispheric glioma H3G34 mutant, is because these are grade 4 lesions, even in the absence of high-grade histologic features. So you don't need to see mitotic activity, vascular proliferation, or necrosis. If it's a diffuse glioma in the midline with the H3K27 alteration, it's automatically a WHO grade 4 lesion, even though it may appear to be a low-grade glioma on histology. So it is important to test for this mutation when you're suspecting, when you have a diffuse glioma in the midline region. Similarly, the diffuse hemispheric glioma, which have mutations in the same gene, the histone 3, but it's a different amino acid. Instead of amino acid 27, it's amino acid 34. They're also automatically WHO grade 4 lesions, even in the absence of high-grade histologic features. So these are two entities here that may look like low-grade tumors on histology, but they're actually not. And that's where molecular testing and molecular characterization of the gliomas becomes important. And lastly, we're going to spend a little bit more time talking about the adult type diffuse gliomas, which is the includes the most common tumors that we see in the adult population. And in the 2016 classification system, we had all these entities of adult type diffuse gliomas. We had diffuse astrocytomas, IDH mutant or wild type, grade 2, anaplastic astrocytomas, IDH mutant or wild type, grade 3, and the glioblastomas, IDH mutant or wild type, grade 4. We had the oligodendrogliomas and the oligoastrocytomas and anaplastic oligoastrocytomas, which are old entities that we now don't utilize these names to refer to these tumors anymore, because the oligoastrocytomas can be classified as either oligodendrogliomas or astrocytomas based on the molecular alteration. So these entities were eliminated, and they're not present in the current WHO classification system. Now, in 2021, we've removed the word diffuse and anaplastic for the astrocytomas. So we no longer say diffuse astrocytoma or anaplastic astrocytoma or anaplastic oligodendroglioma. So this modifier that was associated with the grade, so diffuse astrocytomas were grade 2, anaplastic astrocytomas were grade 3. We no longer use that distinction, and we just refer to them as astrocytomas and give them the appropriate grade. So now things have been simplified. In 2021, in the new classification system, we have 3 categories of adult type diffuse gliomas. We have the astrocytoma, IDH mutant, and this can be grades 2, 3, or 4. We have the oligodendrogliomas, IDH mutant, and 1p19q co-deleted. We need to have both of these alterations for the tumor to be oligodendroglioma, and they can be either grade 2 or 3. And we have the Glioblastomas, which by definitions have to be IDH wild type, and they are grade 4 lesions. Note that there's no longer a glioblastoma IDH mutant, like in the previous classification system. IDH mutant tumor, if it has high-grade fissure, it would be an astrocytoma IDH mutant to ratio grade 4. That's what we used to call glioblastoma IDH mutant grade 4 in the past. Now, there's some molecular alterations that have been incorporated as part of the grading system, and in particular in astrocytomas IDH mutant, homozygous loss of CDKN2AV corresponds to a grade 4, and that is regardless of histology. And this means that I can have an astrocytoma IDH mutant with no mitosis, no vascular proliferation, no necrosis, which on histology would be a grade 2 lesion. However, if the tumor has homozygous loss of CDKN2AV, it's not a grade 2 tumor, it would be a grade 4 lesion because these tumors behave poorly. So it's important to test IDH mutant astrocytomas for homozygous deletion of CDKN2AV for appropriate grading. And in the case of glioblastomas, which are IDH wild type and grade 4 tumors, there are 3 alterations, TER promoter mutations, EGFR amplifications, and combined gain of chromosome 7 and loss of chromosome 10, which can be used to assign a grade 4 to an IDH wild type astrocytoma, even in the absence of vascular proliferation or necrosis. If it's a diffuse astrocytoma and it's IDH wild type, and we have one of these alterations, it will be a grade 4. We no longer need vascular proliferation or necrosis to make the diagnosis of grade 4 glioblastoma. Now, this is a summary of the most common genetic alterations on the adult type diffuse gliomas. We have the IDH mutation, which is critical for accurate diagnosis and grading. In addition to the IDH mutation, the oligodendrogliomas, we have 1p19q co-deletion. They also have inactivated mutations in these genes, CIC, FEBP1, NOTCH1, and they have mutations in TER, activated mutations in TER. So this combination of an IDH1 or IDH2 mutation with a TER promoter mutation is characteristic of oligodendrogliomas. We have the IDH mutant tumors that do not have 1p19q co-deletion, so 1p19q intact. They frequently have inactivated mutations in TP53 and ATRX. So IDH mutation, P53 mutation, ATRX mutation. It's the classic triad for diffuse astrocytomas IDH mutant. And we have the IDH wild type tumors that do not have mutations in IDH1 or IDH2. And they frequently have activated mutations in EGFR, TER promoter mutations, just like oligodendrogliomas that also have TER promoter mutations, but these tumors are IDH wild type, so no IDH mutations, and that's an important distinction. And they frequently have mutations in P10 or NF1 and CDKN2A. So I'm going to give you an example of a 24-year-old patient with a lesion. Here we can see T2 hyperintense lesion. We see in the flare sequence that there's hyperintensity at the periphery, but there's no hyperintensity in the center of the lesion, and there's no contrast enhancement in the T2-1 with contrast sequence. So this is a non-enhancing glioma in an adult patient. You would suspect, based on the imaging, some low-grade glioma. We have a T2 flare mismatch sign, which corresponds to this T2 flare hyperintensity with the hypointense center, and it's distinct from the T2 sequence. And that's characteristic of IDH mutant astrocytomas. So whenever we see a lesion that shows T2 flare mismatch on imaging, we automatically think IDH mutant astrocytoma. And we can know this before we look at the tissue, before the surgery has been performed. You can formulate almost with certainty that the diagnosis of this patient is going to be an astrocytoma IDH mutant if the T2 flare mismatch sign is present. This is an article that was validating this sign in a large number of patients, and they had 100%, but it's very high positive predictive value. I'm sure if we look at enough patients, we might find one exception, but for the most part, T2 flare mismatch sign equals IDH mutant astrocytoma. And here we have 8 different patients with the T2 flare mismatch sign, and all of these patients had IDH mutant astrocytomas confirmed by tissue analysis. So all of these patients are tissue-proven IDH mutant astrocytomas. Now, this particular patient, here we we see the H&E stain. We see hypercellularity, some mild pleomorphism. There's no mitosis, no vascular proliferation, no necrosis. We know this patient had a T2-FLAIR mismatch sign, so we are suspecting a grade 2 lesion. Under the 2016 WHO classification, this would have been a diffuse astrocytoma, WHO grade 2, and that would have been the end. Now, we know that here we can see the IDH1, R132H immunohistochemical stain. So there's strong and diffuse expression by the tumor cells for this mutant protein. Here you can see at higher magnification, the tumor cells express the IDH1 mutant protein. However, this blood vessel in the center, the endothelial cells, do not express IDH1 R132H mutant protein. So the mutation is not present in the endothelial cells, it's present in tumor cells. P53, there's strong and diffuse expression of P53 in the majority of tumor cells that correspond to the presence of a P53 mutation. And ATRX, which is the other important marker in the characterization of adult-type diffuse gliomas. And here we see that the blood vessels retain normal expression of ATRX. However, the tumor cells that are here in the background are negative. There's loss of ATRX expression in the tumor cells, and that corresponds with the presence of an ATRX mutation. So by immunohistochemistry, we have been able to do a molecular characterization of this glioma. It has an IDH1 R132H mutation, likely a P53 mutation, and an ATRX mutation. And that is the triad of diffuse astrocytic disease. So IDH mutant astrocytoma. These are the three categories. And we can do that by immunohistochemistry. And that is a great advantage because you don't have to send the tumor for sequencing in order to make this diagnosis with accuracy. But that's not always the case. And in many of the low-grade tumors, you actually do need sequencing, some type of molecular characterization in order to arrive at a precise diagnosis. So in 2016, this tumor would have been diagnosed as a diffuse astrocytoma, IDH mutant, grade 2. In 2021, we no longer use diffuse, so it would be an astrocytoma, IDH mutant, WHO grade 2, only if there is no homozygous deletion of CDKN2AB. In the presence of a homozygous CDKN2AB deletion, this would have been an astrocytoma, IDH mutant, WHO grade 4, even in the absence of vascular proliferation, necrosis, or increased mitotic activity. And that's an important change in the new classification system, which is the need to evaluate for CDKN2AB in IDH mutant astrocytomas. I'm going to give you one more example. Here we have a T2 hyperintensity. We can see here the T2-FLAIR. We do not have T2-FLAIR mismatch sign in this patient, so we are not suspecting an IDH mutant astrocytoma. Or at least there's no evidence for it on imaging. It could still be, right? We don't always have the T2-FLAIR mismatch in all IDH mutant astrocytomas. And there's no contrast enhancement. Again, because there's no contrast enhancement, you're suspecting a low-grade lesion on imaging. And this is what the histology showed. And we have hypercellularity, so mild pleomorphism, neuropil in the background. So this is an infiltrating glioma, no elevated mitotic activity, no vascular proliferation, no necrosis. So on histology, this looks like a grade 2 lesion. And in fact, in 2016, this tumor was diagnosed as a diffuse astrocytoma, IDH wild-type, WHO grade 2. This is a screenshot of the actual pathology report. It's IDH1 negative, so it's IDH wild-type, no mutation in ATRX. There was P53 expression in a small subset of tumor cells. So this is different from the previous tumor that I just showed you that had loss of ATRX and strong P53 expression. No BRAF mutation, no CD34 expression, low number of mitosis, and a low Ki67. So all the information that we have from the tissue suggests that this is a low-grade tumor. However, molecular characterization was performed, and this tumor showed a TER promoter mutation, PTEN mutation, Notch1 mutation. The TER promoter mutation, this is one of there are two common mutations in the promoter of TER. This is the most common one. Was present in this tumor. And under the new classification system, the criteria for glioblastoma is the following. You have a diffuse astrocytic glioma with vascular proliferation or necrosis, or one of these three alterations. TER promoter mutation is one of the criteria, EGFR gene amplification, or combined gain of 7 and loss of chromosome 10. So this tumor, because it had a TER promoter mutation, It's no longer a grade 2 lesion under the 2021 WHO classification system. It's actually a glioblastoma, IDH wild type, WHO grade 4. So the same lesion, it's now under the 2021 WHO classification system, no longer a diffuse astrocytoma grade 2, it's a glioblastoma, IDH wild type, WHO grade 4. And this just to highlight the importance of proper molecular characterization for the accurate diagnosis and grading of diffuse gliomas. So just to finalize, just that tumor, this is a histology for that last example. No elevated mitotic activity, no vascular proliferation, no necrosis. Traditionally considered as a WHO grade 2 tumor on histology. It's now a grade 4. So with that, I will end the presentation, and I'm happy to take any questions.